Over to you, sir.
Pointer. Oh, no. Slides. You can start. Good afternoon. First of all, thankful to the entire organizing committee and students to the DGM Ayurvedic Village. Giving me this opportunity to speak on few recent sciences and specialty diagnosis. I think it's a post session. Most of them are already into the state. I think these are little recent advances, all little complicated. I try myself to as simplify as possible through this and to understand it. Before starting with as a journey, already earlier doctors spoke things about the matter of psychiatry in even it being me as I think it's a new. It's over the head of to me. So meanwhile, if I start speaking the allopathic things, I think it will be the same. Probably, I guess. But most of things, as I'm already day to day routine, you will be these like MRI, PET, and all. Okay. We'll go to the slides. Any start. Okay. My primary presentation basically is on understanding the neuropathy, what are the advances, what they're taking place, and advances classic system, and biology, what is the changing, basic, the like a current, past, and what is to be then advanced diagnosis, advances in biological treatment, what is there in last 3 to 4 years, and also the advances in psychotherapy. There is this psychotherapy also is changed. I'll be going on. So if you go with the progress of psychiatry as such from the basic from Aristotle from 500 BC, from till the 20th century. Earlier it was malformation. There is a confusion between body-mind dichotomy in 17th century and all. Over the period of 19th century, it's a very branch psychiatrically. It's a neurotransmitter, synapse, and neurology associated with psychiatry has started. And after that, in the mid 20th century and all, there is a phrenology and also psychoanalysis and anti-psychiatry movement all have started by David Cooper and all. But the phrenology has been, I think just two lines. In the phrenology that earlier they used to tell the intelligency, disorders, and all are depending upon the skull size, shape, and based phrenology. That was a kind of concept had. Psychoanalysis, psychoanalytical theory, Sigmund Freud's and all. That was the basic how the psychiatry illnesses and classified and also have been come up. But in 21st century we are right now is again it's a genome, genetics, and basic connectomes, RDOs. This RDOs again research criteria. All depends on research. We are go to the biological psychiatry, then the psychological psychiatry. This biological psychiatry, how the neurotransmitter in the next slide you can go. Okay. Before the biological psychiatry, what present and future. Basically the past, you have the psychological psychiatry. Like something is happened, some stress is occurred. Due to this stress, disease will come, this depression. This stress, the bipolar affective disorders. The schizophrenia occurred due to the some stress. Okay, this person has a schizophrenia is something was occurred in them. But they used to tell. This is the psychoanalyst. They used to analyze the psychology of a person and they used to give some diagnostic and then the treatment aspects. Over a period, when we currently what we randomize RCTs and then descriptive psychiatry with a phenomenology, that is psychopathology, what we have already structured psychology and the structured criteria for a illnesses, I1 or DSM, and also the neurology. Still, this psychiatry is a part of a medicine, but it's a neurology, psychiatry, pediatric medicine, everything. It's a overlap, and the public health is also overlap. Altogether, when you go up, now it is the prevalence rate psychiatry has increased, as you know. Now the prevalence rate of illnesses is 20% of a population. Severity will be around 4 to 5%. So, if you do this, by considering this as a public problem, that's why it's considered as a public health population, and to prevent the illnesses in psychiatry, that it comes under the preventive medicine even. So, since it's a biological psychiatry, so neurons have involved, pathophysiology, of a illnesses, diagnosis, and treatment, altogether one. So for individualized medicine, for each individual has their own psychiatrist, how it has come up from genetic level, biological aspects. So go next. Next slide. So there are markers. These are the biomarkers like neurotransmitters, neuronal circuits, then neurometabolites, by neuroimaging, neuroimmunological factors, and all. What are the biomarkers? So as we test for something like a infection, is like a like as you test for typhoid, you will test serology examination, and you will the diagnosis as a typhoid. But the same in psychiatry. Currently, what we are doing is psychiatry is we have structured areas. Yes. These are the cluster of symptoms. In this cluster of symptoms, these are the symptoms in depression. For example, anhedonia, decreased interest, decreased sleep, and decreased energy levels. These kind of some symptoms, core symptoms, sadness. So core symptoms are there. Yes, this depression. These the symptoms are there. Symptom-based syndrome we have made as a syndromes. This is after this syndrome we have made it as a disorders. So depressed disorders. But the biological markers for it are there. What are these biological markers? If you go ahead with the neurotransmitters, there are few neurotransmitters. If you go for the so many psychiatric illnesses, these are the neurotransmitters. The levels will be in the synaptic cleft. The basically dopamine, like excitatory neurotransmitter, inhibitory neurotransmitters, and then neuromodulation transmitters and neurotrophic factors even. In that, dopamine, 5-hydroxytryptamine, and acetylcholine, glutamate, glycine, and GABA, norepinephrines, adenosines, endorphins. These are the natural neurotransmitters like endorphin, enkephalins, orexins, like sleep disturbance, again sleep modulators. Then substance P is a pain modulators as a neurotransmitters and more. Still many are there. And what are these neuronal circuits? How these electrical circuits are there? Like that, some circuits are there in the brain. We are trending to the, if there is a disturbance with the circuits brain, what are these circuits? We can predict early if there is a disturbance. How? There are some imaging techniques, modulation techniques, by techniques are there. By that we can come to know what are the circuits are concerned for the illnesses like MDD, major depressive disorders. In major depressive disorders, there are some circuits like striatal, limbic circuits, and the prefrontal cortex, amygdala, and hippocampal circuits. In bipolar, corticostriatal thalamic circuits, and ventroprefrontal cortex with amygdala nucleus accumbens circuit. And then the anxiety disorders like ventrolateral prefrontal cortex circuit, and schizophrenia like CSTS, and prefrontal and basal ganglion thalamus circuit. There are multiple circuits. So in that circuit, it's like as I am telling, taking this prefrontal cortex. In the prefrontal part of the frontal lobe, and then it is connected to basal ganglion, then the thalamus circuits. This entire circuit, in this circuit, something like a disturbances, something like a, neuronal injury, neuronal death, leading to this illness, schizophrenia. So we have come to the point that where exactly in the brain this circuit is being damaged. So we are going towards the biological circuit. That's what I was saying. It's going to be a biological circuit. And then neurometabolites, that's what we are saying. N-acetyl aspartate, glutamate, lysine, choline, and phosphatidylcholine, and phosphocreatine, and neurotrophic factors like BDNF, brain-derived neurotrophic factors, and nerve growth factor, and VEGF, that is the ventral endothelial growth factors. These are the growth factors. If we are finding the levels less in the synaptic cleft, then we can find it out that if you compare with the controls and normals and the person who is diseased, these are the factors will be deranged. Basically, the ratio between the each metabolites will be rearranged. In normals, there is a ratio. How to find it out? Then that is the MRS, magnetic resonance spectroscopy and all. This, I think, next slide. Be concentrated. Okay. Others like neuroendocrinal hormonal levels will be decreased. Like simple like CRH, that is corticotrophin releasing hormones, and TSH, thyroid stimulating hormones, vasopressins, orexins, estrogens, testosterone, and oxytocin. Yes, if I go with each levels, I think these endocrinological tests are occurring since already decades in entire in our country even. Like for example, if you take it as a depression even, so many people without any stress, there is no psychological issue at all, but they come with a depression. Why? Then when we recently, if we check immediately the thyroid levels, if there may be a hypothyroidism leading to the depression. If you treat the hypothyroidism, okay, depressive symptoms are gone. No need to worry about the, again with antidepressants, you go on giving for years, no. Go ahead with the hypothyroidism is a cause of it. Like that, if it is a patient, maximum, I think if they give a prevalence of PMDD, I think premenstrual dysphoric disorder, where we can, even in gadag, what we have done the researches in the community based, we have got almost 4 to 7% of PMDD in young high school girls. So, in them, before the menstrual cycles, they have a dysphoric disorders. So, such patients, if you go ahead with what is the issue? Again, the hormonal issue. The estrogen levels will be less. Due to that, during the premenstrual cycle, before the menses, they had all the issues. So, if you treat with the hormone replacement therapy or supportive antipsychotics, especially antidepressants, and also quite some time of non-sedating benzodiazepines to control their anxiety and stress and impulses. So, like that, if you go with the orexins, again this is a sleep disturbances, sleep cycle issues. Again it is with the orexin level will be dishampered. Like that, again with the neuroimmunological. These are the factors where we are heading towards the biological psychiatry. Like IL-6, interleukins, interferons, gamma, and tumor necrosis factors, interleukin 10, 1, and 6 even. There is, as you know, many psychiatry issues have been emerged in a COVID period. Maybe heard. The psychiatry symptoms, psychiatry illnesses have come up very high with a COVID affected patients. Why? The thing is, when the COVID affected patients during that time, there is a neuroinflammation has taken place. There is an increase in the levels of IL-6 interleukins, and there is a tumor necrosis factors has increased. They are the clear-cut evidence so that the psychiatry symptoms which were not expressed, they all are expressing. They all come with a higher severity of the symptoms. So once we started treating the immunomodulatory drugs, once the treatment for COVID has come down, and over the period that all the immunological factors have come down in the serum, then the symptoms also decreased. During that, symptomatic treatment is more than enough. Like that, we should not consider or code it as a psychiatric illness, and like a kind of a stigma should not be put And also the neuroimaging, like multiple neuroimaging has come. It's basically basic neuroimaging like computer tomography, that is CT scans, MRI scans, but they are, now it is getting old. We are coming up with a functional MRI. Then MRS, magnetic resonance spectroscopies, then PET scans, then SPECT, that PET is positive emission testing, and single SPECT, single photon emission testing, computer tomography, like multiple new imaging techniques have come. And another one is called as magnetic encephalograms has also come. Then multimodal, like we can use the multiple like MRI, MRS along with the EEG. Altogether they are considering and coming to some biological reports. With that we can coming to a diagnosis of this is the illness. So if you go for next, and genetic analysis. So what are these biomarkers? Why these biomarkers are helpful? There are different types of biomarkers. If I go ahead with just for a minute for this, they are predictive biomarkers. In these all biomarkers I have told, they are the early. If you predict, we can predict if there is a disturbance with that, there is the level disturbances, we can predict this is the illness they can going to have. And second one, safety biomarkers. Some of the drugs we are giving, by that biomarkers we can give only this much drug. We can't give above than that. Then like susceptibility or the risk biomarkers. And the diagnostic, these are, I was telling that, these are the biomarkers helping for the diagnostic factor and also monitoring and also the response biomarkers. This pharmacodynamic biomarkers are, if you give something like a risperidone as an antipsychotic drug to a psychosis, how much the level of drugs we should give, like dose of a drug. Like not earlier, okay, give for 2 mg, okay, they will get well. Not well, symptoms are not reduced, give 4 mg. Not well, then again for the 6 mg. It was like that. Or we used to put some scales, evaluate the scores of a pan assess, still it is not come down, so we will go ahead with the increase in the dose. But it's not like this right now. With the biomarkers, we can see the level of the biomarker and we can adjust the dose. That's why we are going to stress it. In the future, it's not like this is the dose, okay, 250 mg you should give. No. Individualized medicine. For an individual who is suffering, by the biomarker we can increase the dose or decrease the dose. We can adjust the dose by seeing the biomarkers. That is going to be come in the future. It's not very far away. Next. Okay, just I think it's in detail. What is the genetics, how it is going to be right now? There are some questions they were asking in earlier session that the person with OCD or schizophrenia, what is the, in further next generation they are going to, how to prevent it or how to do. Now it has come to the genetic engineering and genetics, epigenetics basically. I'm not going to take the genomics and transcriptomics and basically proteomics and other things. If you go for epigenetics, the basic DNA sequelae is not at all changed. Only demethylation and histone changes can change the illness. That genetic engineering they are doing. By the genetic engineering, they are reducing the severity of the illness. So epigenetics is the next future and it's a boom right now in the psychiatry basically. By that, they are producing new drugs. By epigenetical drugs. If giving that drug, it is going to change the demethylation and histones in the body. By that, the disease can be controlled. This genetic engineering is really helping in some of the neuropsychiatric illnesses, especially in Alzheimer's and Lewy body dementias and Parkinson's. It's already tried. It's on the pipeline. Next. Okay, what is the current classificatory systems in our psychiatry? Basically, right now, still we are using ICD-10, International Classification of Diseases, and then DSM, Diagnostic Statistical Manual, it's a US based, and it's a WHO has given a ICD, and US is practicing a DSM. So they are structured the criteria. That's what I was saying. On the criteria, we are diagnosing and we are treating. ICD-11 and ICD-DSM-5-TR is a new one, and we are following right now with the ICD-10, but we have to shift to the ICD-11 and DSM-5-TR criteria. But what is this RDOC? This is the new. What NIMH, in the UK-based NIMH is given, RDOC is research domain criteria. Earlier, what we used to do is, next slide you can go. Earlier, what we used to do, we will diagnose with the criteria. Okay, these are the symptoms. We will go for some illness, like this is a mania, this is a schizophrenia, this is the OCD, this is a PTSD, or it's the anxiety spectrum, generalized anxiety disorder, or a postpartum psychosis. With the criteria, we will diagnose it. Then we will go over the treatment, other diagnosis. Okay, this is there or not in the brain. Then you give the treatment. But RDOC is different. We can start with the functional aspect. Basically, research from the genetics, circuits, neuronal molecules, then the behavior. What is the behavior is changed? The psychiatry is also called as behavioral sciences, human behavioral sciences. So what is the behaviors are changing? Why this was changed? So it is not from the top to bottom approach, it's the bottom to top approach. Next slide. Okay, next. So this is what saying, bottom to top, bottom up approach, what we are saying, with the circuits and going for the behavioral changes, is going to be individualized medicine. Not with the symptoms, behaviors, and understanding the pathophysiology and mental illness. This is the current what we are using still today. The next and recent advances are occurring with this, like bottom-up approach. Next. So, okay, if you go in detail with the research domain criteria, they have made it as a 5 criteria. They're basically in psychiatry, entire psychiatry, they have made negative valence symptoms domain and positive valence symptoms, cognitive symptoms, and social processing domain, and also arousal regulatory system. If you go ahead, next. So in a column, if you have and otherwise, there is a genetics, molecule, cells, circuits, and physiology, behavior, and self-report. That has entirely, they have come up with a both together associated table. Next. So this is how the behavior. If the behavior with a fearfulness, potentiality, so what genetic, molecule, cells, circuits, what is the affected one? From there, they go on checking, then over a period we are going to get these are the behaviors. This is the research domain criteria of a NIMH is going ahead with new researches. On these researches, we are making the individualized medicine. They are giving a personalized or the individualized medicines, but I don't know, still it is going under the research. And with this, after the entire research work, they are going